All right. Thank you, everyone, for your patience. I think we can start the presentation. First off, thank you for coming to this grand round. My name is Bao. I am one of the medical SHOs who is currently working on DSHAM ward. We have a great case to discuss today, which was brought up to us in our M&M meeting, which we did yesterday afternoon. Without further ado, let's start the presentation. So, routinely, we have these M&M meetings to discuss or review deaths as a professional learning point, and cases are selected by the medical examiner, who believes there are room for improvement, plus minus having opportunities in them to learn from. So we have 5 points to cover in these meetings: to clinical governance and the opportunity to discuss cases and how we can learn from them, and into potentially improve the patient's safety and to improve patient care overall. We have recently devised a set of questions in which to extract from patient's document and to pinpoint key documentations and what we're looking for. And these are whether there are prompt assessments and senior reviews, and whether investigations and treatment, example antibiotics, were appropriately given and in a timely manner. The third one is, were there any problems getting a timely investigations, or investigations were suitable? And whether or not a VTE prophylaxis was considered, and if so, was it given throughout the admission and documented to do so? Were there any appropriate responses to the deteriorating patients, and with documentations of sealing of care and respective paperwork, were they done for patients that are needed? And with good communications for patients, family and carer were looked into as well. So as I said, there was a great case that we discussed in yesterday's M&M meeting that we'd like to highlight and share with everyone in this grand round, hopefully to pinpoint some great learning points. So without further ado, this patient that we discussed yesterday is Miss R.S. She is an 85-year-old female with a background of asthma, PMR on a low dose of maintenance steroids, gout, type 2 diabetes, who is on tablets and insulin, CKD, hypertension, and liver cirrhosis. She's not known to be an alcoholic at all. She is from a memorial care center as a respite and is fully mobile, independent, with a frailty score of 7. So she presented to us at Conquest Hospital on the 31st of December, after the nurses noticed that this patient was a bit lethargic and had a low-grade temperature. So a routine blood glucose was done, and it showed a glucose level of 2.1, and hence why the ambulance crew was contacted immediately. Sorry, there's some background noises. Sorry, can someone mute their mic?
I can hear you, Bar. Yeah.
Thank you very much. So, as I said, this patient came in with hypoglycemia and was rapidly corrected with glucogel during admission. And as you will see later on, it was monitored quite well throughout the admission. It should be noted that the patient was recently discharged from a gastro ward in Eastbourne, having a long stay there for decompensated liver cirrhosis, aka right leg cellulitis, and a poorly controlled diabetes, and treated with drain, IV fluids, antibiotics, and reviewed again by the diabetic team. The patient came in, we did routine bloods on her, and it showed an elevated CRP of 150 and a white cell count of 18. A chest x-ray was also done, querying this, where the source of low-grade temperature was coming from. And from the image itself, there's no obvious consolidation shown there, and it was later on reported by the radiographer to show no real significant finding or consolidation found there. So the clerking doctor up in AAU, correctly so, started the treatment of infection query source, aka on CKD and hypoglycemia, with IV antibiotics, and the CSU was sent. It should be noted again that the patient has a catheter which was inserted in the previous admission on the 25th of November. So bearing in mind that the clerking doctor has to do a VTE, which was correctly done so, and Clexane was given throughout admission. The blood sugar, as I said before, was rapidly corrected. If you look in the top right-hand corner, when the patient came with 2.9, it was corrected and monitored quite severely. And it was stable. Only one episode of hypo later on the admission on the 12th of January, dropping down to 1.6, again correctly and rapidly corrected and maintained at a normal range. The patient started to spike temperature on the 2nd of January. So bearing in mind this is over the bank holiday weekend. Friday the 1st is New Year's, it's a bank holiday, and Saturday, Sunday. So on the Saturday, the patient started spiking temperature, blood cultures were correctly taken, and the nurses correctly gave the paracetamol to potentially lower it down. Unfortunately, there were no documentations of a doctor reviewing this patient at all, despite having multiple spikes in temperature, peaking at 38.9 and again 38.5 on the Sunday. If you look on the top right-hand corner, there's an entry from the site manager. They were informed about this temperature. Query to inform doctor advised not to by site as patient already on antibiotics and blood culture. Again, over the weekend after the junior doctor has clocked the patient in, no doctor had reviewed this patient. So the patient's post-take ward round occurred on the 4th of January. That is on the Monday, about 4 days after the patient was admitted. So over the weekend, there were no senior review for this patient, not until the Monday where the ward team came back and reviewed her. It was clearly documented. Fortunately, we were working with the same diagnosis, sepsis of unknown origin, considering the patient's spiked temperature. From the consultant ward round, noted that the patient had a distended abdomen and arranged for an ultrasound consequently. This came back with extensive ascites noted throughout the abdomen. So the patient was started on the IV antibiotics for sepsis of unknown origin as per the micro guide at the time, which was coamoxiclav and gentamicin IV. Unfortunately, the gentamicin level after the first dose was over 4.0 and advised by the micro consultant to switch to tazocin. So this was an effective, timely mannered alteration and was correctly done so by the parenting team. A few procedures were done. In terms of the extensive ascites that was picked up on the ultrasound scan, the parenting team did an acidic drain, and the culture that was sent to the lab had no growth and a SAG gradient of greater than 1.1 suggestive of portal hypertension. It should be noted that the patient was previously admitted on the Eastbourne, I forgot to mention, sorry, for leg cellulitis treated with antibiotics. This time round, as per the clerking doctor, there was no oozing, no signs of infection of cellulitis, but again, we did a leg swab anyway, querying a possible source of the sepsis. This came back as negative as well. Blood cultures correctly done, taken on admission date, came back no growth after 10 days. And Unfortunately, the patient contracted COVID during the hospital stay whilst treating for the sepsis of unknown origin. The swab was done routinely on day 6 of admission on the 6th of January, and the report came back positive on the 8th, 2 days later, which again was on a Friday, so nothing much was done there. Fortunately, the patient was not hypoxic, was saturating 95% and above on air. Again, was afebrile until the 12th. We continued the antibiotics on that Monday and was deemed medically fit after being afebrile for at least 24 hours. And we were just awaiting for the physiotherapist to review the patient. If you take note of the news score on the 13th of January at 1:45 at the end, the bottom right hand, the patient was using a 0 afebrile, 100% saturation on air, but unfortunately had a cardiac arrest. Two hours later, patient was unresponsive on the ward. The SHO, rightly so, commenced CPR on the patient. ITU consultant and the the consultant on call was called to the unresponsiveness, the cardiac arrest, sorry, and decided to stop the CPR due to poor prognosis. And the patient's next of kin was updated immediately. Going back to the list of questions that we devised for the M&M meeting, was there prompt assessment and senior review? Unfortunately, no. Patient spike in temperature over the weekend, no doctor review, junior doctors or ward doctor to review the patient, and consultant or senior review was not done until 4 days after the admission. Investigations and treatment were appropriately timed. Yes, the antibiotics was given as per protocol, and the ultrasound scan, for example, was requested, and chest x-ray looking for sources of infection. Any problems getting timely investigations and results from specialists? No, we didn't have to seek many specialist advice, if any, but results and scans were requested and performed in a timely manner. VTE, as you see, the Clarkin doctor done correctly and prescribed and was given throughout the admission. And in regards to the deteriorating patient's response, it was done in a timely manner. CPR was started immediately, and a cardiac arrest call was put out in a timely manner. Unfortunately, sealing of care and the respect paperwork, given the patient is an 85-year-old lady with severe frailty, I believe a frailty score of 7 with quite a few comorbidities, I believe a respect form should have been done during that admission. Communications with the patient's family carer post-death was done correctly and was documented as well. So from our learning points, what we learned from the M&M meeting, we picked up 3 points, was to ensure that all patients are handed over efficiently and, more importantly, over the weekend / long bank holiday weekend, so that to emphasize the long bank holiday weekend to make sure that all patients are seen by a senior review. To ensure ward doctors are aware of a newly admitted patients and that they have been seen by a senior. And thirdly, to ensure respect forms and appropriate documentation or sealing of care is done if deemed appropriate, especially for frail patient, for example, this one here. And so that concludes our presentation and our case that we discussed yesterday on the M&M meeting. If there are any questions, we are more than happy to answer them.
Well, I think it's important that the list, what do you call this?
Post-take water on list. Yeah.
Yes, I think it's important that we constantly need to check if there's a post-take done on our admission list, especially over the weekend, because I think this is the lifeline that we need in order to know where the patients was transferred to, and if the post-take has taken over or not. So I think it's both responsibility of the on-call consultant, at the same time the SHOs that's going to work together with that consultant to update the lists so that you are constantly aware of the post-take happened or not.
Yeah,
I think going forward from this case, basically, we have seen, and I'm sure all my colleagues have seen that in few occasions, basically, we do have every now and then a case which gets missed from the post-take ward round, more noticeably over the weekend. You come on Monday, you find the patient sitting on your bed, Clark management started, but no senior review over the weekend. Thankfully, no major incidents happened so far, but this doesn't mean that basically we should carry on and just close our eyes. We have tried different sort of things. Some of the consultants quite paranoid, and they will check the list every now and then. Juniors sometimes get busy. Yes, they will review the patient with the consultant, but they don't have time to, or sometimes they forget to update the list. But what I found, basically, it's at the end of the day, we are one team. Doctors, either senior or junior, nurses, HCAs, whoever get involved in the patient's care should basically share the load. And I noticed that the nurses have got what they call checklist, handover checklist. When the people get transferred either from A&E or AEU, they do go through the things one by one. Patient seen, yes, tick the box. Dementia screen done, yes, tick the box. I think we should ask them to add one list, basically. Has the patient been post taken? Yes, tick the box. Basically, to ensure patient, and wherever the patient goes, if that box hasn't been ticked as post-take ward round, nurses in that ward should alert the site manager, who subsequently should alert the admitting team to alert them that there is patient has been missed for post-take ward round, so they can alert the consultant. Because honestly, we have raised these things before, and just relying on the junior doctor or the consultant, it's not like doing enough. I think we should do more. Thank you.
Thank you, Dr. Hadid. Are there any other questions or any advice in regards to what we can do to improve and avoid this incident again? Okay.
Hi, I'm Daphne, and I am midfielder on AAU. And just to add to what Dr. Hadid has just said,
Okay.
I think it's just the fact that we need to be able to liaise with site team, so patients are not being transferred without being seen first or without being posted. And the reason being, we are so stressed for beds down here. So we would automatically just transfer patient as per site manager's advice. But if just as Dr. Hadid has just actually clarified, we are all here to look after such patients, and we need to be able to have this open conversation very clearly as to what the expectations are, especially with the site team.
Yeah, it's not a matter of basically preventing the movement of the patient. That's fine. You can move the patient from anywhere to any ward. But the main thing, basically, first of all, how safe to move the patient. That comes first, regardless whether the site you are under pressure or not. Basically, if it's not safe, not safe. Now, if it is safe to be moved, we need to make sure the post-take ward round has happened. If it's not, still the patient can be moved, but we need to highlight that. I'm not saying basically do not move the patient to anywhere without senior review. That's absolutely fine. You can move them as long as it's safe to do so. But We just need to highlight, like the dementia screen. Dementia screen hasn't been done, and you will find basically the ward clerk highlighting that to the team in the ward. We need something to highlight for the consultant or the junior or the nurses in that ward. Basically, you know what, we have a patient who hasn't been post taken, and we should do our best to get the consultant in charge to come and post take the patient. I'm not against moving the patient. No, I'm against moving the patient unsafely. That's first thing. And if we are moving them, if they're safe to be moved, then has the post-take ward round has happened or not? If not, then we need to alert the consultant to go and post-take that patient.
I understand. I think it's just for us to be more aware. And for me in AAU, I'm not sure if there are any other matrons on this round. Is something for me to be aware of. I do understand, and I do understand the pressure about beds. And as you said, I'm just sort of agreeing with you. We need to just highlight the fact that the patient's not been seen yet. Yes, we can move them off, but some form of handover on the HS bar that we use, as you know, maybe we can add that onto it.
Yeah, I 100% agree with that, Daphne. Thank you very much for that.
Yeah. Any other suggestion, guys? How can we improve?
Yeah, thank you very much for this presentation. Yeah, I think sometimes what's happened is a patient during the handover in the weekend, we know where they are before we go into the ward to do the ward round, post taking on the ward. There is another consultant in AAU. I think between this time, when we move to the patient around like 9:30, so AAU consultant who's doing the post taking haven't seen the patient, and in the post take list by the consultant who's doing the post take on the ward, in their list, the patient is still in AAU, so that kind of missing the patient. So I think it is going to come in for a long bank holiday during this Christmas and New Year time. So we'd like to make sure that's not happen again. So how are we going to prevent that one to happen again? So that's a good idea. Whether that checklist can be added to the nursing staff, but whether the nursing staff will communicate to the doctor regarding this. So I think another way we can, there's a kind of polite reminding. We always doing double checking whether we have done all these post taken or not. But when we're doing the ward post taking, I think when we go to the ward, check with the nurse in charge and the junior doctor who is on the ward, in the assigned ward. Also check with the nursing staff who are the new patient and whether that has been post-take or not. And if not been post-take, I think that can be escalated to the post-take consultant straight away. Yeah.
Well, I have a suggestion here. What about, I mean, for the last, how long now we've been doing the two consultants on the weekend, one covers AAU, one covers the outlier. I think we've been doing that for a while now. Why don't we create a very quick meeting between these two consultants, the one covers AAU and the one covers the wards, before, I mean, at around, like, say, for example, 11 o'clock, they meet together in AAU and they double check. I mean, each consultant would have his list, isn't it? Just go quickly through the night, I mean, the previous day list, and double check the location of each patient one by one, just to ensure basically people who are still in AAU are still in AAU, people who have been moved within this critical time. As you said, sometimes people gets moved at 7 o'clock, and in our list they are still in AAU, but actually they have been moved somewhere else. Then they can identify that one, and the consultant in charge can chase them up. How about that? and we can basically let Agnes to circulate to all the consultants Saturday and Sunday before when they finish their checking the outliers, whatever. Say for example, they finish the outliers at around 1 o'clock. They have to go back to AU, double check with the consultant who is there, and make sure that all the indication of the patient are still correct as per their handover sheet.
Yeah, that's also a good idea then.
And we can email Agnes to circulate all the consultant to ensure to do this quick, let's say quick handover on Saturday and Sunday.
Yeah, that's a good idea. Any other suggestion? Any question?
If we're not pushed for beds, I think you guys can insist that the patient gets seen here in AAU before they get transferred.
Yeah,
that's absolutely fine.
Yeah, that's the ideal, definitely. Because sometimes the consultant will highlight something, for example, or maybe how many times we found that there's basically we need other specialty involved, and sometimes they just get taken over by somebody else.
Yeah,
fighting downstairs in the ward. It's easy for the other specialty to take the patient from AAU, other than if they stuck in one of the medical beds. Basically, it's very difficult for that team to get the patient to move to the right specialty. But I know basically sometimes it's very difficult. You are under too much pressure in terms of beds, and you just want to move the patient. But ideally, patient shouldn't have been moved from AAU before a senior or consultant review.
These ground rounds should have site managers involved in it, because this conversation has to be around all of us, so we know exactly, this sort of scenario that you've just shared with us is really important.
Yeah.
And we have to learn from these things. There's no need for us talking about it among nurses and doctors, and people who make decisions are not here.
Yeah.
Of course.
Yeah. But I don't know how to. I mean, we can.
Agnes can send an email to head of site.
Yeah.
He's Emma Joshandas, and they can just be invited.
Dr. Wan, how can we feed back to the site managers? We are, my team, basically, we are more than happy to represent this in some sort of other meeting, if you like.
I would forward you the name for head of site, and I'll copy my heads of nursing into it as well.
Yeah. Yeah. As I said, basically, we are more than happy to represent this case and re-meet at some point, especially we're approaching the Christmas period, and we will be in the same situation as well.
Yes.
Dr. Kankam has a question.
Okay.
Hello. Thank you very much for highlighting a very important problem. Obviously, we all agree that this should be a never event and should never happen again. There are two ways of getting this, bringing this to the attention of our leadership. Is we could also use the medical division meeting. And if you're happy to present a summary of your recommendations, the medical division meeting, which happens monthly, then we could, as a division, invite the bed management team to say that because of such and such and previous experience, these are expectations for people who are admitted. And I think if we get that done and it becomes a policy or document, then we would have a duty to stick with what those guidelines that we agree on are. And the second thing about consultant to consultant handover is to be encouraged. I mean, I'm sure most of us try to do it, but this patient clearly slipped through whatever safety nets we had. I think that's a good point. Thank you.
Thank you, Dr. Kankam.
Thank you.
Dr. Wing,
Yes.
may I ask whether this incident was highlighted to the governance team?
I would double check. We discussed yesterday that should be fill up the incidents form if not been done. I don't know whether that has been done before or not. This case we discussed yesterday as part of our MNN case. Yeah.
Because you
Yeah.
can
If not been
contact,
done, that should be Datex. Yeah.
yeah, or you can contact Margaret England, and she might be able to disseminate the information to the important people.
Yes. Usually she attended our MNM
Oh,
meeting, but
okay,
yesterday
all right.
no. Yeah. Yeah, we
Okay.
will email and CC about these discussion to her as well. Yeah.
Okay.
Dr. Kankan, hands on. Is there any more question? No.
Might be just
Yeah.
historical.
Yeah.
Previous one. Yeah. Okay. Oh, thank you very much for all these positive discussion for
Yep.
the case. And if you have no more question, then I think we can stop here.
Right.
Thank you for attending.